Did y'all have a good long weekend?
Yes.
Good. All right. So before we get started with all of our electrolytes, do we have any questions of what we talked about last week? No. All right. Then all right, so we'll just kind of review a little bit about potassium and kind of talk about lower potassium levels again. I need to make sure I record and let everybody's muted. Okay. So we talked about potassium and how even very small changes in potassium levels are going to affect our body. It does affect every body system, but it very much will affect any kind of muscle cells or nerve cells. So with the heart being a muscle, that becomes really important in recognizing high and low potassium levels. So we talked about with low potassium levels, your common causes are going to be with inadequate intake. They're not taking in or eating potassium-rich foods. Also with your diuretic use, like your Lasix or your potassium wasting diuretics are going to make you urinate all that potassium out. Anything that makes you lose your fluid volume. So with your diuretic use, any kind of GI fluid loss through vomiting or diarrhea, profuse sweating, starvation, all those things are going to make your potassium leave. And then with DK, of course, you're urinating a lot if your blood sugars are way high. Same thing with diabetes insipidus. And then dialysis if they're just taking off too much when they dialyze you, and that could potentially make your potassium go low. So it's going to be any levels below that 3.5. And what we'll see is those shallow respirations. You may see anxiety, confusion, some weakness or fatigue. Those leg cramps. Remember I said your grandma says go eat a banana if you got leg cramps because you don't have enough potassium. You may see heart arrhythmias. If that level gets too low and your heart muscle's not getting enough potassium to it, then you're going to see arrhythmias. You might see a weak, low, thready pulse and decreased GI motility. So some things we're going to do for that low potassium level is, of course, we're going to encourage or give potassium. If it's a low or a minimum loss, so say you have a 3.3 or 3.5, you may just encourage those potassium-rich foods, or you're going to give some PO potassium capsules or tablets. If they're not able to take PO or they're super low, we may end up giving IV potassium. And remember, IV potassium can be quite dangerous. It does tend to burn your vessels, so you're going to want to run that slow and dilute it if possible with some normal saline. So you would just hang a bag of normal saline and then your little potassium bag and run them in at the same time. And remember, we don't give IV potassium IV push because that will kill somebody. That's what they do with lethal injection. And then we're not going to give it sub-Q or IM because it can be very irritating to the tissues and can cause tissue damage. Remember too, if we have really low levels, we may have them on telemetry because our heart muscle is being affected. It's not got enough potassium, so we might be having those arrhythmias. So we want to have them on telemetry to catch any of those. All right, so with hyperkalemia, so that's when our potassium level is too high. So that's going to be a serum level of greater than 5.0. And I'm going to share my screen here. All right, so we have hyperkalemia. So we have greater than 5.0 milliequivalents. Okay. If you have something, or if you have a level greater than 6.5, that is going to also be a medical emergency. You need to do something ASAP, because just like with low potassium levels, if it's too high, your patient's going to be having crazy heart rhythms, and at this level, they could very easily code. Some reasons of why we're going to have high potassium levels, of course, would be diet. They have too much potassium. From different foods, different medications can also make your potassium level go up. And the use of salt substitutes. Salt substitutes are very high in potassium. Zoom's not working. Uh-oh. Oops. Well, hopefully if it records, then y'all will be able to watch it later. So any patients that have high potassium levels, make sure that they're not putting salt substitutes like Mrs. Dash on their foods, because that's going to increase their potassium levels. Okay. Having renal failure. That is going to, your kidneys are not functioning. They're not getting rid of that waste. So you're going to end up having a accumulation of potassium if your kidneys aren't working. So you're not able to excrete. Then if you have, we had our potassium wasting diuretics, so now our potassium sparing diuretics potentially put us at risk for higher levels. So if we are we're voiding, but they are sparing that potassium, so it's still holding on to it even though we're voiding, it is going to increase our risk for higher potassium levels. And these are going to be your diuretics like spironolactone. Or aldactone. Okay. Having acidosis, so being in an acidotic state, is also going to increase your potassium levels. Remember how we said alkalosis makes your level low, acidosis makes your level high. The use of ACE inhibitors. So all of your drugs that end with pril, those are going to put you at a higher level of retaining your potassium. And then any kind of cellular destruction like burns or trauma. Can cause you to have an increase in potassium. I think I remember reading one time that it's because those cells end up getting damaged, and they release all the potassium that's within them out into the bloodstream. So that's why you're going to see elevated potassium levels with burns and trauma, because those cells got damaged and released all of their potassium. I will say the most common reason that you will see high potassium levels is going to be your renal failure. Those are going to be your patients that you'll see it most often in, because their kidneys aren't working just to get rid of their potassium. All right, so in our assessment, all right, so let's assess with hyper. All right, so with hyperkalemia, we're going to see muscle weakness and twitches. So muscle twitches are actually an early sign of high potassium. And then muscle paralysis is a late sign. You may have paresthesia, which is going to be numbness and tingling. And a lot of times, I did not spell that. Paresthesia. That's still not spelled right. You may see this around the mouth. Perioral numbness. You may see anxiety. You may also have a low heart rate and low blood pressure. You're obviously going to see those EKG changes. If your heart's getting too much potassium, it's going to go all crazy, and you're going to have those EKG changes. And then you're going to have hypermotility of the GI tract, so that's going to lead to abdominal cramping. And then you may also have diarrhea because of that. Okay. Then, what are we going to do to fix our too high potassium levels? All right, so the first thing we're going to do is educate them to decrease their diet, right? We want them to not eat that whole batch of bananas. So your potassiums that are high in food, if you look at the little cheat sheet, a lot of your diet foods that are rich in potassium are going to be your toes. Is that sheet that I gave you where it's potatoes, tomatoes, and then for some reason it has banana toast and avocados. So those are the things you can teach them to try and avoid. Those are your foods that are high in potassium. And remember, I said those salt substitutes, there's a gnat flying around, sorry. Those salt substitutes are going to be higher in potassium, so you want to make sure you're educating them to limit or to avoid their salt substitutes. So if we have too high of a potassium level, there's a couple medications that we can give. So what do you think we can give? What medications caused our potassium level to be low? Or what issues?
ACE inhibitor.
ACE inhibitors. So we're not going to do a whole lot about that other than maybe if the doctor wants to change or take them off of that. But remember, we're losing, when you have your potassium and you're losing it, it's going out.
Potassium sparing diuretics.
So we're going to do we're going to give them potassium wasting diuretics. So we may change up if we have too high or too much potassium. We may give them
a loop diuretic.
Yes. So we're going to give them loop diuretic. We're also going to give them a drug called Electrolytes. And Electrolyte can be given oral or enema. And it basically makes them poop like crazy. So that you are pooping out all of that potassium level. Or all of that potassium. Sorry, my kid's trying to show me something. All right, so what Electrolyte does, it actually exchanges sodium with potassium. And it makes that potassium go out in the stool. Remember how I said at the very get-go that sodium and potassium have that reciprocal effect? So it's going to trade places so that potassium is going to leave those cells and it's going to trade places with that sodium and it's going to be pooped out. Okay, so we're going to make them poop. Other than that, we can also give them calcium gluconate. And this is given IV. It's usually in a piggyback. And what this does is it doesn't really make you lose your potassium. It doesn't make you do anything to lose potassium. It just kind of decreases that myocardial irritability. So it kind of gives your heart a buffer so that it's not going too crazy because of that too high potassium level. All right, so that's just going to be like a buffer. Then we're going to give, as weird as this sounds, we're actually going to give them dextrose or D50. Okay, and regular insulin. Sounds kind of like it contradicts itself, right? Well, what this does, the combination of giving lots of sugar water and insulin at the same time, it actually makes the potassium shift back into the cells rather than being out freely in the fluids or out in your bloodstream. It's within the cell. Okay. Then we may also give them sodium bicarb. And this just makes your cells more alkaline, and it causes your potassium to shift back into the cells. And we're going to give that IV as well. And we already said your loop diuretics. And I have not figured out the function yet. I've been wondering this my whole life. But albuterol, nebulizers actually will also make you lose potassium. So if you have a patient that has, let's say, a potassium level of 6.0, that's pretty darn high, right? So we're going to call the doctor, let them know. He's probably going to order some Lasix. He's going to order Electrolyte. He's going to order IV calcium gluconate. He's going to order D5 and regular insulin. And he's going to order albuterol nebs, all trying to get that potassium to shift back into the cell. Okay, you might see that sodium bicarb, but it's given less often than your other items. Okay. And your regular insulin for this purpose is usually given IV push. Sometimes it's given sub-Q, but it can be given IV push because it's usually in really small increments. Okay. So what else do you think we might do for this patient who has a high level of potassium? We're going to stick them on telemetry as well. So anytime you have a patient with a too high or too low potassium, they're going to be on a cardiac monitor. They're going to be on telemetry because we want to closely monitor what that heart's doing. Okay. We're also going to measure nose because we want to look at their kidney function, right? We want to make sure their kidneys are able to excrete that excess potassium. So we're going to measure their eyes and nose. And if it's your potassium level's too crazy, high and out of whack and nothing's working, we may get them on dialysis. Oops. Okay. So dialysis can be done on like acute renal failure patients. It's a one-time, two-time thing. They don't have to go on that for lifelong. If it's emergent and they can't get that potassium level down, they may get dialysis. Okay, so we're essentially going to do things that are going to make them pee and poop to get that excess potassium out of their system. We're going to monitor their heart and monitor their output. Okay. Any questions on potassium? Nope. All right. So then we're going to move on to calcium. So your normal calcium level is going to be 9 to 10.5, and that's milligrams per deciliter. Okay. 99. So 99% of calcium in the body is located within our bones. And then only 1 little percent is in our extracellular fluid. So that's not much. So what calcium's going to do, we're going to look at our parathyroid hormone. So our parathyroid hormone is our main regulator of calcium. And it also distributes it. Okay, so it's going to regulate and it's going to send it out to the body. So what happens is your parathyroid hormone stimulates release calcium into that extracellular fluid. So it's telling your body that it needs some calcium. So it's going to release that calcium from the bone and send it out to your bloodstream. And what that does then is it causes your kidneys to reabsorb calcium. Okay. Are y'all still having troubles with Yep, they're still having troubles with Zoom not working. Okay, so PTH, or our parathyroid hormone, regulates our calcium and is in charge of distributing it. So it's going to stimulate that release of that calcium from the bones into that extracellular fluid, making the kidneys to reabsorb it so that it can get in your bloodstream. Okay. So does anybody know what you have to have in order to make calcium work?
Vitamin D.
Absolutely. So you have to have vitamin D. If you do not have adequate vitamin D, your calcium is not activated, basically. So you need vitamin D to activate the calcium. Okay. Oops. In the bloodstream. So vitamin D is going to allow absorption. Of calcium by the body. All right, so we have to have that vitamin D. That's why you'll often see calcium tablets with vitamin D included, because that calcium's not going to work. You can keep taking it and keep taking it, but it's not going to work without that vitamin D. And especially in people who like the indoors, don't get very much vitamin D, because what are two of your main sources for vitamin D?
Sunlight.
Sunlight, and what's the other one?
Your diet.
Say that again.
Diet.
Diet, what specifically?
Milk.
Dairy.
Milk. So milk is vitamin D fortified. So if you don't drink dairy products and you're not going outside much, you're not getting enough vitamin D. So you're going to have to take vitamin D to make that calcium work. Okay. So we may need to make sure we're educating our patients on that. All right. So calcium is also important. It participates in enzyme reactions. It helps with membrane excitability, so it helps with muscle contractions and nerve impulses. It's actually going to also help in blood clotting, and it helps in teeth formation, as well as bone. Okay, so we need our calcium. So what happens when we don't have enough calcium? So we have hypocalcemia, not to be confused with hypokalemia. Don't get tripped up on that on a test. Okay. So that's going to be a level of less than 9.0. Okay. So some of our causes are going to be hypoparathyroidism. So with hypoparathyroidism, we have a lack in secretion of that parathyroid hormone. Okay, so if we have a parathyroid tumor, or we had to have our parathyroids removed and they're not working quite right, they're not going to excrete that parathyroid hormone, telling the body that it needs some calcium. Okay, because remember, that's what's going to release that calcium into the bloodstream. You may also see it in alkalosis. You may also see it if a patient gets multiple blood transfusions. Oops. Due to a preservative in it called citrate. Citrate binds to calcium and renders it basically inactive. So if you've got somebody who's just getting blood transfusion after blood transfusion, they may have low calcium levels because that citrate is causing their calcium to not be effective at all. Plain and simple, inadequate diet. Or sunlight. So if they're not taking in enough vitamin D or calcium or both, you're going to see lower levels. And increased laxative use. So what that does is just it interferes with the absorption of calcium as well. Also remember that calcium is primarily absorbed in the small intestine. So if you have issues like Crohn's disease or ulcerative colitis, if you've had gastric bypass where you don't have as much stomach and intestines, then you may have low calcium because you have decreased surface area of adequate intestine to absorb that calcium. So, I think with Crohn's. Because, yeah, you just don't have that enough good healthy tissue in that small intestine, so it's going to affect your absorption of that calcium. Okay. So what are we going to see in an assessment? So with hypocalcemia, our most common thing we're going to see is going to be paresthesia. So we're going to see numbness and tingling. Numbness. The hands and feet. That's going to be your most common. You may also see confusion, memory impairment. You may have irritability. They may even have like hallucinations. They may have tetany. So tetany is an involuntary contraction of muscles. So they may have where their muscles just kind of like freeze up. They don't move. Okay, so involuntary. Involuntary muscle contraction. So I'm going to put frozen muscles.
Miss White, would it be something like a Charlie horse?
Yeah, Absolutely. All right, I'm going to erase this up here actually. Well, let me do that. It will. Cool. All right. So with the tetany, we may also see, oh, it disappeared. Deep, was that deep tendon reflexes? They're going to be hyperactive. Okay. You may also see seizures. Let's see if this will erase right here. Ah, it erased all of it. I was trying to not erase everything. Sorry. So we're going to have hyperactive deep tendon reflexes. We might see seizures. Then we might also see something called a positive Chavostics sign. So what this is when you tap on the facial nerve that's kind of right in front of the ear, it causes like facial muscle contraction and twitching. And the way I remember that Chavostics sign is it starts with a C and you're tapping the cheek. Okay. So tapping the cheek or that facial nerve by the ear. Facial twitching. Okay, and there's on your PowerPoint slide, there is a picture of what that might look like. So that one, my cat is in my face. So we have positive Chavostics sign. We may also have what's called a positive Trousseau sign. And what that is if you put a blood pressure cuff on a patient on their arm and you squeeze it up and you leave it there for 3 to 4 minutes or so, you will see tingling and numbness in that hand or in that arm. And it kind of makes that tetany occur where your hand muscles and arm muscles kind of freeze up and go into that funky position like in that picture that I've got for you. I will say, I don't know that anyone has ever tested this. I have not seen it done in 25 years, but we still teach it.
I've seen like the doctors do it. I've never seen a nurse do it though.
I've never seen it happen. So they're going to see spasms. Okay. All right. So what else are we going to see? Those are going to be like your neurovascular or your neurologic symptoms. So what are some things we might see cardiac-wise? We may see a weak, thready pulse. We may see hypotension. We can also see heart arrhythmias with this. With that, we may see heart palpitations. For our respiratory system, we may see laryngospasms. And that can lead to respiratory failure, airway failure, if your larynx is freezing up basically and spasming, you can have a compromised or blocked off airway. With GI symptoms, you will have hyperactive bowel sounds. So if you have hyperactive bowel sounds, that's going to lead you to believe that we're going to have diarrhea and cramping, right? Then with musculoskeletal, if you have low calcium levels, you're going to have bone fractures, right? And that's going to be due to bone demineralization. So in these patients, you're going to see osteoporosis, right? In your elderly. In children, if you have low calcium levels, you might see something called rickets, but that doesn't occur very much these days anymore. But of course, we all know about the elderly getting osteoporosis and breaking a hip because they're not getting enough calcium. They may also have muscle cramping and muscle spasms. And their calf muscles. Here's your Charlie horse. Okay. They do tend to notice this most often at bedtime or when you're resting. All right. I'm going to try and just erase this side here. All right, so what are we going to do? Interventions for hypocalcemia. So we know we need to teach them to increase calcium in their diet, right? We all know that those items are things like dairy products, milks, cheeses, dairy, milks, cheeses, yogurts. Any of those items are going to be high in your calcium. We do try to have them increase their intake level to around 1,000 to 1,500 milligrams daily of calcium. Okay. With that, we need to make sure that they are taking their vitamin D with that so that we can have that calcium absorbed. Because without that vitamin D, our calcium doesn't do us any good. We may give them calcium carbonate. Y'all know what that is? Tums. So every once in a while, you'll see where you're giving your patient like 2 Tums 3 times a day. And that's going to help to replace their calcium. We can give them, if they have really low calcium, we can give them IV calcium gluconate. And this is going to be for severe treatment. Okay. This can also be very irritating, so you're going to run it slow. It's given IV piggyback. So we're going to give it slowly because of irritation. Any of your electrolytes that you give are going to be irritating to your tissues. Of course, we're always going to have everybody on fall precautions. And then remember with over here, I have in our assessment with low calcium levels, they may be at risk for seizures. So we're going to have these patients on seizure precautions. Now tell me what that includes.
Paddings in the bed rails.
Mhm. Side rails.
Bed position.
Say that again.
Have the bed low instead of
Yep. Having the bed low. Sometimes you may have an oral airway at the bedside, which is essentially just a curved piece of plastic that if they do have a seizure, you can put it in their mouth. If it's safe, you obviously don't want to risk breaking their teeth or damaging their airway. But most often you're just going to see those padded side rails. And then I have on there to ensure adequate PO intake of fluids. Ensure adequate fluid intake. So this is super important. And if you have a patient, because I want to make sure that I get this clear. So they're not taking in lots of PO fluids because they have a low calcium level. They're going to make sure we have adequate fluid intake if they're taking calcium supplements. Okay. So if taking calcium supplements. So they're got a low calcium level. So we're going to give them supplements to fix that problem. But now we could potentially run into the problem of, anybody know? No.
Dehydration.
Good thought, but they are at higher risk for kidney stones because kidney stones are often, not all the time, but often made of calcium deposits. If you're taking extra calcium, then that can build up in your kidneys. So you're wanting to make sure that you are keeping those kidneys good and flushed out. Okay. And we do encourage them to take around 2,500 mLs per day to flush kidneys to prevent kidney stones. So with that, like I said, it's not because they have low calcium, it's because we're treating them for low calcium. So we're giving that calcium, putting them at risk for those kidney stones. So we want to make sure that if they're taking their calcitrol, then we're getting enough fluids in them to prevent those kidney stones. Okay. All right. Then we have hypercalcemia. So we have too much calcium. So this is going to be levels greater than 10.5 milligrams per deciliter. So what are some common causes for hypercalcemia? Hyperparathyroidism. So the opposite of hypo, you have hypothyroidism. With hyper, you're going to have the cause of being hyperparathyroidism. So what do you think that parathyroid is doing?
Producing too much.
Yep, it's releasing too much calcium into the bloodstream. Okay, Makes sense, right? I won't delve into this, but just know that some metastatic cancers can lead to higher calcium levels, and those are going to be things like multiple myeloma. I cannot spell. That's not how you spell that. Sometimes breast and ovarian cancer can as well, and those essentially just secrete substances into the bone cells that make that calcium level increase. And I don't expect you to know that and which ones cause it. Okay. Some of your thiazide diuretics.
Huh?
I was telling my mom that it's been a series of good days. We're blessed.
Yep.
So no tears, no regrets, nothing. We're just happy instead of.
So thiazide diuretics. And this is going to be things like HCTZ. Those tend to decrease calcium excretion.
So
So it's building up in their system.
You like that, I know.
What?
You like the heat.
I keep using. All right. And then obviously if we have a diet that's high in calcium and vitamin D, then you're going to see increased absorption. So you're going to have higher levels. Increased absorption. So when we assess our patient with hypercalcemia, we're going to see neurologically, we're going to see decreased tendon reflexes or decreased neuromuscular excitability. Okay. They may have impaired memory. They may have bizarre behaviors.
Miss White,
Yes.
what does the DTR stand for?
Deep tendon reflexes.
Okay.
So like if you tap their knee with a reflex hammer, it's going to be slower to respond. Okay. They may also have lethargy. They can have a coma or go into a coma and headache, fatigue. Cardiac wise, you may have hypertension or dysrhythmias. I know I spelled that wrong. I'm looking
I
at,
have a question.
yes,
So when you say bizarre behaviors, like what do you mean?
just kind of acting, I'd say acting more spontaneous, not thinking quite right. They just might be acting goofy, which is out of their normal, just kind of not their normal baseline.
Okay.
Nothing real specific. Just
Okay.
not
Okay.
themselves, basically. With renal system, you're going to see polyuria. You may this isn't renal, but you may see polydipsia, so they're extra thirsty. And they have high calcium levels, so what else do you think we might see? Renal stones. You're going to see those kidney stones from that excess calcium building up in their kidneys. GI, that should actually be where polydipsia is, so excess thirst. You're going to see hypoactive bowel sounds. So with hypoactive bowel sounds, we're likely going to have
Constipation.
Yeah.
Constipation.
And we may see nausea and abdominal pain. Musculoskeletal, I'm just going to put muscle weakness because that kind of goes up there with the neurological with the deep tension reflexes. So muscle weakness and those decreased DTRs. So you're going to be slow to respond with your reflexes. And one thing that you wouldn't necessarily think of is you may see bone pain and fractures. And this is because your bones are more weakened because calcium is pulled out of the bone and into the bloodstream. So you got high levels of calcium, so you wouldn't think that you'd have fractures, but your calcium's not in the right place. It's not in the bones. It's going to be in your bloodstream. Okay. All right, so our interventions. What are we going to do for too much calcium? Well, with their diet, we're going to have them have a low calcium diet. So cut back on the dairy products, right? And it will often be less than 400 milligrams. 400 milligrams daily. We're going to increase that fluid intake. Because remember, they might, they're at risk for those kidney stones. So we're going to increase their fluids. And I don't expect you to know this, but just FYI, or drinks that are high in what are called acid ash. And these are going to be things like cranberry juice and prune juice. They tend to decrease the risk of your kidney stones the best. We want them to increase their fiber intake because we have that slowed GI motility, so we're going to have constipation. So we want to increase their fiber to prevent that constipation. For your medications, we're going to give loop diuretics because this is going to cause us to excrete any excess calcium. We may take calcitonin. And what calcitonin does is given to decrease those calcium levels by decreasing renal absorption. Thereby, it increases excretion. But it also helps prevent the breakdown of bone cells into the bloodstream. So it helps lower calcium levels. Okay. And I always think of calcitonin as it tones down your calcium levels. So it's going to help lower them. These patients may also take biophosphates. Those are going to be things like Fosamax and Actonil. And that just decreases the progression of osteoporosis. So remember, these patients, they have lots of calcium, but it's not in their bones. It's in their bloodstream. So we have these biophosphates that are going to help decrease that bone loss from the osteoporosis. We may also give corticosteroids. Corticosteroids are actually going to inhibit calcium absorption in the intestine and bone reabsorption. So it's going to inhibit calcium absorption. And then we may give them isotonic fluids, IV fluids. And this is just going to dilute the calcium levels. And with excretion. Okay, so we're basically just flooding them with fluids so that they can excrete those fluids and pee them out so that they'll lose that excess calcium. Okay. Any questions currently? No questions? All right, then we'll take a 10-minute break and come back at 11. We'll come back at 11:10, so 8 minutes. All right, and then we'll go over sodium. All right. So I'm going to erase all this.
Miss Walker, not Miss Walker, I'm sorry.
Yes.
Before we keep going. So when a patient has low calcium, we're going to check for renal stones because we want to give them calcium supplements, correct?
Correct.
And for hypercalcemia, they are at risk for renal stones because of too much calcium.
Right.
Okay.
So with both of them, you're going to make sure they're flushed out. And I know that trips people up sometimes because they're like, well, I know it's with high, but it is with low too because you're giving them the supplement.
Right. Yeah.
All right. So next we will talk about sodium. If my computer will type. All right, so normal sodium is 135 to 145, and that is milli equivalents per liter. All right, and remember I told y'all that little saying when we were talking about fluid balance of where sodium goes, water follows. So that looks at fluid balance and just at our sodium in general. Sodium is our most abundant extracellular fluid. Extracellular fluid. And our main purpose of sodium is going to regulate fluid balance. We're going to regulate fluid balance. It also helps with muscle contraction. So it's also important for our heart. And it helps with nerve impulses. All right. So sodium is obtained, or we get our sodium from our GI tract. So what we drink and eat, GI tract obtains. Oops. Okay. And our kidneys are the main regulator. So our kidneys are going to tell our body whether or not it needs to hold on to that sodium or if it can let go of it and excrete it, right? Oops. All right, so I do have on there too that sodium imbalances can actually occur in all fluid situations. So whether you have a perfect fluid volume, whether you're dehydrated or overloaded, you can still have altered sodium levels. It just kind of depends on where the sodium is, whether it's inside or outside the cell. Okay. All right, so if we have not enough sodium, so hyponatremia. Okay, that's going to be sodium levels less than 135. So our common causes, and I don't want you to get too caught up in the actual deficit versus relative deficit. Don't fixate on that. But with hyponatremia, it's going to be caused by dilution as a result of excess water or too much sodium loss. So dilution of excess water or an increased sodium loss. Okay.
Did you mean hypocalcemia there?
Oh, no, I did not. Neutropenia. There we go. Thank you. All right. So our most commonly given causes are going to be our GI deficit. So we're going to lose from vomiting. We're going to lose it because of diarrhea. We may also lose it from NG tube suctioning. And excessive tap water enemas. Just remember, we're diluting it. With integumentary system, we're losing fluid, we're losing salt, and we're losing sweat, right? So with diaphoresis. So if we're really diaphoretic and sweating a whole lot, we're losing all that salt and fluid when we're out exercising. We can also get this with severe burns and excess wound drainage.
Can you elaborate on the NG tube suction? Oh, I thought it said secretions. I'm like, what?
NG tube suction. So if we're sucking out all their inner, all their GI content. So this too, with low sodium, you're taking all their inside fluids and they're going out. So all that sodium is going out of their system, causing it to be low. With the renal system, we're going to have diuresis. The endocrine system, we're going to have decreased aldosterone secretion, which will lead to a decrease in sodium. Okay, medications like our diuretics. We're peeing a lot, so we're going to lose all that salt. And then our ACE inhibitors. So just like it made us lose potassium, or made us gain potassium, depending on if we're looking at high or low, it's also going to affect our sodium as well. And then with our diet, if we have an inadequate intake of salt. So we do need some type of salt. We just don't want to overdo it. Then just looking at the relative deficits, excessive IV fluid intake of hypotonic fluids. Having hyperglycemia can also cause it. It causes water to be pulled out of the cells and into the extracellular fluid, causing dilution. The SIADH that Ms. King will talk about next unit, that's going to cause major diuresis. So you're peeing out all that sodium. And then we talked the other day about third spacing, how that is an excess of fluid just outside in the interstitial spaces, and that fluid's not doing us any good. So that is diluting your sodium levels, just having all that excess fluid out in your tissues. Okay. All right, so basically takeaway from that is anything that causes fluids to leave your body is going to take the sodium with it. Okay. So our assessment for low sodium. So neurologic, we're going to see headaches. We may see irritability. They can be restless. You may see hallucinations with this as well. And they are at risk for seizures. Cardiac-wise, this one may trip you up just a little bit. So if we have a sodium loss, we are going to see an increased heart rate. So we're going to see tachycardia and decreased blood pressure. Okay. But if we have water excess, then we're going to see increased blood pressure and tachycardia. So I think of this as where we're thinking about back to our fluid balance. So if we have a sodium loss, so we're dehydrated. Think of sodium loss as you're dehydrated. You don't have enough fluids or enough sodium. So with that, remember our blood pressure dropped because we didn't have enough fluids. We were dehydrated. And our heart rate went up because it's having to work to compensate to try and increase that blood pressure. Okay. Wherewith if we have water excess, so think of your patient with congestive heart failure or they're retaining fluids, they're going to have increased blood pressure because they already have excess fluid volume. Their body's having to work extra hard to try and move that fluid around. So they're going to have that increased blood pressure from working extra hard, plus that heart rate's just going to try and stay up, still trying to move all that fluid around. Okay. All right. Then with respiratory, we're going to see tachypnea. With fluid volume excess. So again, think of your congestive heart failure patient. They've got excess fluid volume. So they're going to have shortness of breath if they're holding on to too much fluids. We have shortness of breath, and we're probably going to hear some crackles, right? With the GI system, we might see nausea, vomiting, diarrhea. We may have cramping, and we may have anorexia, so not wanting to eat. With the integumentary system, we're going to have two different things here too. So with hypovolemia, so we're dehydrated, right? So with that, what are we going to see with the skin? We're going to see pale, dry skin if they're dehydrated, right? Then if it is due to hypervolemia, we're going to see edema. A good description would be like doughy skin. They have all that excess fluid in there, so it's kind of doughy. And like think of pitting edema. And you might see that third spacing. With musculoskeletal, you might see weakness, muscle twitching, and muscle spasms and cramps. When you think of your sodium imbalances, think too of your fluid volume balances. They kind of go hand in hand there. You've got too little fluid volume, then you're dehydrated and you're going to have those dehydration symptoms. Where if you have excess fluid volume, then you're going to have that swelling and crackles and respiratory issues. All right. So what are we going to do for these patients with low sodium? An easy peasy fix is increase their sodium intake. They get to have salt. So we're going to increase their salt intake. And these patients may also be on free water restrictions. So these are the patients that they're drinking lots of water, so they are diluting their bloodstream. So we may end up restricting their water so that they're not diluting the salt out too much. So your foods that are high in salt, just think of milks, cheeses, any of your condiments like ketchup, of course, salt itself, bacon, ham, different processed foods. So they get to eat all that. Then with your medications, we have oral medications that we can give them, and it is simply sodium chloride. And I always tell my patients that here, this is your salt lick, because it is literally a salt tablet. You may see them taking salt tablets. For your IV fluids, they're probably just going to get normal saline, at 0.9% normal saline. If it is very severe, you may see that 3% to 5% hypertonic solution. Okay, but remember that is in extreme conditions, and these are going to be your critical care ICU medications for that 3 and 5%. Okay. We're going to educate them. Educate on signs and symptoms of hyponatremia. We're going to encourage them to replace fluids lost during exercise. So if they're out sweating and working hard, they need to replace. That doesn't look right. And in hot weather. So just making sure that they're hydrating. We also want to do daily weights on these people, as well as eyes and nose, because we want to monitor their fluid volume, right? And then these patients too, we're going to get seizure precautions. So we're going to pad their side rails. Okay. Any questions on hyponatremia? All right, so then next we look at hypernatremia. So that's going to be your sodium levels are greater than 145. So some common causes is dehydration. So what this does is it increases the concentration of sodium in your bloodstream. So it's going to make your sodium level high. Inadequate water intake. Not one you see very often, but if you have excessive intake of salt water. So if you have a patient that was like a near drowning in the ocean, you may see hypernatremia. Excessive intake in their diet of sodium. So they're having too much salt, too many salty foods. Of course, IV solutions, like if we're giving our 3 to 5% in critical care, if we're not keeping a close eye on them with those hypertonic fluids, then we can cause their level to go up. Kidney failure, because they're not able to excrete, because their kidneys aren't working, so they're holding on to all that excess sodium and fluid. It can also come from excessive water loss. So if you're losing fluid, but your sodium's still hanging in there, you're going to have higher levels. And this can come from vomiting, diarrhea, or watery diarrhea. Diuretics, burns, sweat, fever, anything that's going to make you lose fluid volume. Okay, so we've lost too much fluid from sweating or whatever out there exercising, but it is causing a major concentration in our sodium level. So that's why it's going up. We've lost the fluid, but that sodium has stayed in our system. So what might we see in our assessment? So the first is going to be your very first symptom to appear. However, remember what populations I told you that didn't necessarily work for?
The elderly and children.
Yeah. Because their thirst mechanisms are not quite intact. All right, and then you will also see dry mucous membranes. Okay, so with dehydration and hyper or high sodium levels, you may see them be agitated, confused. They're at risk for seizures as well. They also have muscle twitching. We're going to see tachycardia with the heart racing. Again, this is going to be like with your hyponatremia, with being dehydrated or being hypovolemic, you're going to see a low blood pressure, but with a high heart rate, trying to compensate. However, if you're hypervolemic and you have too much fluid volume, you're going to see high blood pressure and a high heart rate. Okay. With respiratory, you're going to have dyspnea again. Just from fluid volume gain. And then GI, again, are going to have that watery diarrhea.
I'm sorry. Can you confirm you said with hypernatremia, you're going to see high blood pressure, high heart rate?
Mm-hmm. Well, because remember with your high and your low sodium. So if you are hypovolemic, and even though you have a high or low sodium level, so if you're hypovolemic, you're going to have your heart rate is going to be up and your blood pressure is going to be low. This is if you're dehydrated. But if you're in fluid volume overload or hypervolemic, your heart's still going to be pounding. It's still going to be working hard. But you're going to have an increased blood pressure because of all that excess fluid it's having to pump and move around. Okay. All right. And then here too, like with the dyspnea, that's if you have that excess fluid volume. If you're dehydrated, you're obviously not going to have that or hear crackles or have shortness of breath. So your sodium, it really depends on where your fluid is. Okay. They go hand in hand with that fluid balance. Our interventions. So their salt level is too high, so we want to decrease their sodium intake. And typically we give patients that are at risk for cardiac issues that 2-gram sodium diet. So they may be cut back on that. So we're going to restrict sodium intake. We're going to ensure adequate fluid intake. We want to administer hypotonic IV fluids. Because we want to pull that. We've got, if our problem here is our cells are shrunken up and shriveled up because they've got too much salt going on, we're going to rehydrate those cells with that hypotonic solution, right? So we're going to make it do the opposite by giving it these hypotonic solutions to cause that fluid to go into the cell. Okay. Then with your medications, we might give loop or thiazide diuretics. To promote sodium loss by increasing excretion. With our education, we're obviously going to teach them to decrease that salt intake with their foods and their diet. And avoid medications that contain sodium, and that's going to be things like Alka-Seltzer. Okay. And then, of course, we're going to put them on seizure precautions. So if y'all haven't noticed, your seizure precautions are with all of your electrolytes except for potassium. Potassium, you're going to think heart monitor, telemetry. Your other electrolytes, you're going to think seizure precautions. Okay. All right. Any questions about sodium? Because lastly, we'll go over magnesium, and then that'll be all that y'all have to learn. We don't make y'all learn all of them. All right, so magnesium. So a normal magnesium level is a 1.5 to 2.1, and that is also milliequivalents per liter. And magnesium plays a very major role in activating enzymes for metabolism. It also helps with transmission of nerve and muscle impulses. It actually powers the sodium potassium pump in your heart. And then it also has or plays a major function in your central nervous system and your cardiac system. Ooh. Okay. If we didn't have the right electrolytes, our heart and muscles would be in big trouble. So if we have hypomagnesemia, that is going to be a serum level of less than 1.5. Okay. Your common causes for hypomagnesemia is going to be like malabsorption disorders, like having inflammatory bowel disorders, such as Crohn's or ulcerative colitis. Having prolonged diarrhea. Having an ileostomy. Anything that causes nutrients to not be absorbed properly in that small intestine is going to potentially lead to low magnesium levels.
What was the UC?
Ulcerative colitis. And then these patients that have had bowel resections. So they had part of their bowel removed. They're going to have low magnesium levels because they have a decreased surface area in which their body can absorb stuff.
It's White.
Yes.
What's the IBD?
Inflammatory bowel disorders.
Thank you.
Those examples are going to be Crohn's and ulcerative colitis. Then, obviously, your decreased PO intake of magnesium-rich foods. Intake, and that will lead me to alcohol abuse. So, it is very common to see in alcoholics to have low magnesium levels because they are not getting proper nutrients because all their intake is primarily alcohol. So I think it was you, Eddie, that mentioned last week about the banana bag. This is where your banana bag is going to come into play. Is with your alcoholics are the most often people to get banana bags or rally packs, they're also called, which is a bright yellow IV fluid that has all of the electrolytes that these alcoholics are missing, one of them being magnesium. You will see that very commonly in them. And then diuretics are going to increase renal excretion. Okay, so just like with the other ones, if your kidneys are working and you're taking diuretics, you're peeing out all those electrolytes. Okay. Where on the flip side, you're going to have higher levels if your kidneys aren't working and you're retaining all those electrolytes. Okay, and then you'll have higher levels. So with our assessment, what are we going to see in these patients? They are going to have mood changes. You may see them being very apathetic. Might have confusion, hallucinations, and guess what? Seizures. Muscular, you might see muscle twitching. They might have muscle tremors. They're going to have hyperactive deep tendon reflexes. And then again, you might have that positive Shavastic sign and positive Trousseau sign. And how do we tell the difference between the two? How are we going to test for Shavastic sign?
Either the cheek or the bone in front of the ear.
Yep, so we're going to tap the cheek and that facial nerve right in front of the ear, and that's going to cause facial twitching. And the Trousseau sign is where you put the blood pressure cuff on the arm, and if it's positive, then it causes that muscle tetany or that contraction and numbness and tingling in the fingers. You can also see your heart arrhythmias with this. And you may have decreased GI motility, so we're going to see constipation. Learned about paralytic ileiasis yet with surgery? So paralytic ileus is basically where your intestine kind of freezes up and doesn't want to move, and it can lead to small bowel obstructions because your bowel's not moving along and churning like it should. So it'll cause you to get an ileus. So our treatment for hypomagnesemia is obviously increase PO intake. So your foods higher in magnesium are going to be things like legumes. I laugh every time I say that word. Legumes, whole grains, nuts, and dark veggies. We can also give medications, and we can give them PO magnesium oxide. We usually just abbreviate it mag oxide. So we're going to give that orally. We can give magnesium containing antacids, like Malox, I think, has some magnesium in it, or milk of magnesia. You can give them that. With your IV, we're going to give IV magnesium sulfate. And that is typically done in a drip, and it is going to be given slowly as well. Okay, so it's going to be piggyback. So another one to give slowly. Okay. It doesn't normally cause that burning like potassium does. They usually tolerate it pretty well. Okay. I will say with mag sulfate, you want to give that slowly because if you give too much, then you put your patient at risk for respiratory or cardiac arrest. Because like with your low magnesium over here, you've got your hyperactive deep tendon reflexes. So if we're giving them magnesium and that level gets too high, especially too quickly too high, it's going to cause a decrease in your deep tendon reflexes. So your muscles are not going to be working properly. They're going to be slowed. So you're going to be at increased risk for respiratory or cardiac arrest. Patient education is just going to include nutritional teaching, and we're going to put them on seizure precautions. All right. Oops. All right. So lastly, we have hypermagnesemia. And that's going to be levels greater than 2.1. And our common causes for that are going to be our renal failure, because our kidneys are not working. They're not excreting that magnesium and those other electrolytes. So it's going to cause our magnesium level to go up. And increase in oral intake. So if they're eating too many legumes, then they are at risk for having too much magnesium. Also, if they're having taking too many of those magnesium-rich antacids, so if they're taking milk of magnesia every night, it could put them at risk for higher magnesium levels. And then untreated DKA. So it just having those high blood sugars can alter the effect or the movement of how glucose and magnesium move in and out of cells. So it can cause higher levels of magnesium. So in our assessment of hypermagnesemia, we are going to see lethargy. We're going to see drowsiness and decreased level of consciousness. If we have high magnesium, so if we're running a magnesium drip, we may see those decreased deep tendon reflexes if we have too much magnesium. So muscle weakness. So because of that, we may have heart dysrhythmias. I can never spell dysrhythmias. Dysrhythmias and arrhythmias always mess me up. I don't know why I can't spell that. We may see hypotension and bradycardia because we have muscle weakness, so everything's slowing down. So we may have bradycardia to the point of asystole or cardiac arrest. And then we may have nausea and vomiting. Okay. Oops. So then our treatment for too much magnesium is we're obviously going to avoid foods high in magnesium. Avoid those legumes. Sorry, I can't stop saying legumes. We are going to hydrate. We're going to increase their water intake to promote kidney or renal excretion. So we want them to get that out of their system, so we're going to push fluids like crazy. So remember with the high potassium levels, where we had that myocardial irritability, and we wanted to provide that buffer to help protect that irritability and protect that heart muscle with calcium gluconate. We're going to do the same thing here with magnesium. We're going to give that IV calcium gluconate IV slowly to antagonize the effects that magnesium is going to have on the heart. We're going to give diuretics to increase excretion. And we're going to give IV fluids, just probably some normal saline, to increase that urinary output, increase excretion. And then we're going to do patient education and just teach them about proper diet. And then they may, again, if it's like that potassium and it's crazy high, they may end up having to do dialysis to get that down. Okay. Any questions?
When will you be sending out the study guide?
I will send that out today. Let's go ahead and take like a 5-minute break, and then we'll come back, and I have some practice quizzes that we can kind of go over.
That will be helpful.
So that you can kind of see how questions are going to be worded as well. So we'll do that in 5 minutes, and then we'll call it a day if y'all don't have anything else.
If I have a cardiac arrest.
So I've got two little practice quizzes that I used last year that seem to help people think through and get used to how I'm going to word questions. So we'll look at those two. And I thought I had them like available to pull up for you to look at, but I could not find them a minute ago. So I'll just have to read them to you. And these are going to include questions of everything on the unit. So it's going to include fluid balance, it's going to include acid base, your blood gases, that kind of thing. Okay. Excuse me. All right, so the first question is, on your morning assessment of your patient in room 2502 who has severe burns, you notice that fluid is starting to accumulate in his abdominal tissue. You note that his weight has not changed and his input and output are equal. What do you suspect? It's going to either be third spacing. This is normal and expected after a burn and is benign. Document this finding as non-pitting abdominal edema or intravascular compartment syndrome.
Compartment syndrome? Read the question. Read the answer choices one more time, please.
It's going to be either third spacing. This is normal and expected after a burn. Document the finding as non-pitting abdominal edema or intravascular compartment syndrome.
That one. Intravascular compartment syndrome, maybe?
Abdominal edema one.
So it's going to be third spacing. So third spacing is when you have that traumatic or tissue injury where all that fluid is just kind of sitting out and serving no purpose. Remember how I talked about in the abdomen, you're going to have ascites, and it's that kind of fluid, that excess fluid in there where you can kind of see the water. Compartment syndrome has to do with orthopedic stuff. That's when a cast is too tight. So this patient with severe burns, who's got abnormal tissue just kind of floating around and that's serving absolutely no purpose to him in his abdomen. So that's going to be third spacing. Which patient is at greatest risk for an electrolyte imbalance? A is an 8-month-old with a fever of 102.3 and diarrhea. B is a 55-year-old diabetic with nausea and vomiting. C is a 5-year-old with RSV. And D is an 87-year-old with intermittent episodes of gout.
A.
Hey,
The child.
So you have your 8-month-old, which isn't going to have a great amount of surface area on their body, and they're going to lose fluids faster. And with a fever of 102.3, they're probably diaphoretic and losing fluids. And with the diarrhea, they're definitely losing fluids. So that's going to be your patient that's at greatest risk. The next is a patient is admitted to the ED with the following findings: a heart rate of 110, a blood pressure of 80/62, and a urinary output of 25 mLs an hour. Which interventions do you expect the provider will order for this patient? So are we going to restrict fluid intake and monitor daily weights? B is administer normal saline and monitor urinary output. C is administer a hypotonic IV solution and sodium tablets. Or D, no interventions are expected.
C. C.
see.
So let's look at this. Our patient, they're in the ED, they have a heart rate of 110, so they're tachycardic, right? But their blood pressure is only 80/62. So they have low blood pressure, okay? And their urinary output is only 25 an hour. What do you think that their problem might be?
Dehydration.
Fluid.
They're very dehydrated. So what is a simple thing we're going to do to fix dehydration?
Normal saline.
We're going to give them normal saline and monitor their urinary output. Okay. All right, the next is after obtaining an EKG on a patient, you notice the patient is having significant changes. Which lab finding would cause this? Which lab value would cause this finding? A sodium level of 140, a magnesium level of 2.4, a potassium of 6.7, or a calcium of 9.2.
Potassium is 6.7.
Yes, absolutely. Potassium of 6.7 is going to have your most significant EKG changes. Okay. Which patient below has at greater risk for having a potassium level of 5.5? Okay. So a 76-year-old who reports taking Lasix 4 times a day, a patient with Addison's disease, a 55-year-old who's been vomiting for 3 days consistently, or a 36-year-old with chronic renal disease.
D, the chronic renal disease.
So, yep, our potassium level is 5.5, so that's over 5, so it's elevated. And your most common cause is going to be kidney failure. Their kidneys are not able to excrete that potassium. So you're going to see very often kidney patients or renal patients having high potassium levels. Okay. The next is you are taking a patient's blood pressure manually. As you pump up the cuff above the systolic blood pressure for a few minutes, you notice the patient develops a carpal spasm. Which of the following is true? The patient is having a normal nervous response to inflating the cuff. This is known as Trousseau's sign and is present in patients with hypercalcemia. This is known as Chvostek's sign and is present in patients with hypercalcemia. Or D, this is known as Trousseau's sign and is present in patients with hypocalcemia.
B, hypercalcemia, Trousseau sign.
So Trousseau's sign is going to be the blood pressure cuff one, and you're going to see it in hypocalcemia. Okay. Which patient is at greatest risk for hypomagnesemia? A 55-year-old with chronic alcoholism, a 57-year-old with hyperthyroidism, a patient reporting overuse of antacids, or a 25-year-old suffering from hypoglycemia.
A.
Your alcoholic is going to be your most common patient with low magnesium levels. In a report from a transferring facility, you receive information that your patient's magnesium level is 1.2. When the patient arrives, you receive an order to administer magnesium sulfate IV piggyback. Which of the following interventions takes priority? A, set up bedside suction. B, set up bedside atropine drip due to bradycardia. C, monitor the patient for reduced deep tendon reflexes and initiate seizure precautions. Or D, none of the above are correct.
C.
Yep, we're going to do C. So their magnesium level is low at 1.2, and we're going to give them IV magnesium. So we're going to assess their deep tendon reflexes, right? Because if they get too much magnesium, we're going to have decreased reflexes, right? So what would we do if we ran into that problem? Our patient's getting an IV mag drip, and we go in there to assess them, and they have decreased deep tendon reflexes. What are we going to do?
Stop the IV.
Hydration.
Absolutely, we're going to stop that IV infusion immediately because we do not want to get them any more magnesium. All right, which patient is at most risk for fluid volume deficit? Here's another one. A is a patient who's been vomiting and having frequent diarrhea for 2 days. B, a patient with intermittent nasogastric suction. C, a patient with an abdominal wound vac with intermittent suction. Or D, a patient fasting for 1 day.
A.
Okay, so that patient that's got frequent diarrhea and vomiting for 2 days is definitely going to be at risk for dehydration. The next is a patient is admitted with congestive heart failure. So that means they're going to have fluid volume excess, right? So which would you expect to find during your assessment? A, flat neck and hand veins. B, a furrowed dry tongue. C, increased blood pressure and crackles throughout the lungs. Or D, bradycardia and pitting edema in the lower extremities.
Increased crackles. Fluid column.
Right. So you're going to see increased blood pressure and crackles. Okay. Does everybody see why D, bradycardia and pitting edema in the lower extremities is not right? If you have a patient with congestive heart failure, they're going to have lower extremity swelling, right?
Mm-hmm.
But are they going to have bradycardia? They're going to have tachycardia because they've got all that excess fluid that they're trying to move and push around. All right. The next. A patient with hypoparathyroidism complains of numbness and tingling in their fingers and around their mouth. The nurse would assess for what electrolyte imbalance. So they have hypoparathyroidism.
Calcium?
We're going to look for a hypocalcemia because their parathyroid levels are low, so it's not telling the body to release calcium. So we're going to look for low calcium levels. The next is a patient is semi-conscious and restless and exhibits tremors and muscle weakness. Assessment reveals dry, swollen tongue and a body temp of 99.8. Which serum sodium level would the nurse anticipate finding? That's a tough one.
Can you reread the question?
A patient is semi-conscious and restless and exhibits tremors and muscle weakness. Assessment reveals a dry, swollen tongue and a body temp of 99.8. Which serum sodium level would the nurse anticipate finding? 120, 132, 142, or 155?
155.
Yes. So the key thing that jumps out at me there is the dry, swollen tongue. So they've got too much salt. When I think about eating too much salt, I think of having that dry tongue and needing something to drink. So that's what kind of clues me in on that one. All right, a patient with a potassium level of 5.5 is to receive K-Exolate orally. After administering the drug, the priority nursing action is to monitor A, urine output, B, blood pressure, C, bowel movements, or D, oral intake.
Bowel movement.
Bowel movement.
Bowel movement. So our 5.5 potassium is too high. So we're either going to give them PO or an enema of K-Exolate. So remember, K-Exolate makes you poop like crazy. So we're going to make sure that that has kicked in and that they are having bowel movements to get rid of that excess potassium. Now, if I had to put Lasix in there, what would we be monitoring?
Urine output.
Yep, urine output. All right, the nurse caring for a patient who has been in good health up to present is admitted with cellulitis in the hand. Well, we didn't talk about this one. So the patient's serum potassium level was 4.5 yesterday, and today it is 7. Which of the following is the next appropriate nursing action? A, let the physician know the results during the next rounds. B, question the results and redraw the specimen. C, encourage the patient to increase their intake of bananas. Or D, initiate seizure precautions.
Redraw the specimen.
Redraw.
I'm absolutely going to redraw that specimen. So yesterday it was 4.5 and perfectly normal. Today it's 7. So if you have that major of a jump in a potassium level, go ahead and redraw that level. Potassium is very well known for being elevated when your blood hemolyzes. So if you shook the little vial too much, or if the blood was coming out too rapidly into the tube, it can actually cause those blood cells to burst or hemolyze, and that will artificially increase your potassium levels. So you'd want to make sure to draw that again and double check it and make sure it's right before you go and treat them for a level of 7 and then make their potassium too low because it wasn't really that high. All right, 5 is a patient is receiving an IV magnesium infusion to correct a serum level of 1.4. Which of the following assessments would alert the nurse to stop the infusion immediately? A is absent patellar reflexes, B, diarrhea, C, premature ventricular contractions, or D, increase in blood pressure.
Absent patellar reflexes.
Yeah, absent patellar reflexes. So that's telling you that your muscles are being overloaded with magnesium and they're not going to work. They're not working very well. So we want to stop that if we notice that absence in reflexes. All right, the next is an older adult patient admitted with heart failure and a sodium level of 113 is behaving aggressively towards staff and does not recognize family members. When the family expresses concern about the patient's behavior, the nurse would respond most appropriately by stating, A, the patient may be suffering from dementia and the hospitalization has worsened the confusion. B, most older adults get confused in the hospital. C, the sodium level is low and the confusion should resolve as the levels normalize. Or D, the sodium level is high and the behavior is a result of dehydration.
C.
C. So a sodium level of 113 is really low and they will probably be very confused. But as you give them their normal saline IV fluids and that level starts to come back up, they should start clearing up and being less confused until they're at their normal baseline. Okay. And 7 is a patient with chronic renal failure receives dialysis. Receiving dialysis complains of frequent constipation. When performing discharge teaching, which over-the-counter product should the nurse instruct the patient to avoid at home? Okay, so they're getting dialysis, they're constipated. What are we going to have them avoid? A is prune juice. B is fiber supplements. C is ducosate sodium or cholase. And D is milk of magnesia.
Probably MOM.
I think it's milk of magnesia.
Milk of magnesia, because that's going to be a magnesium containing antacid or laxative that you could give to patients, but you don't want to give them anything that contains magnesium because you don't want them, they've got renal disease and they're going to be holding on to that just like they were to potassium and everything else. So we're going to teach them rather to do the prune juice or increase their fiber. We don't want them to take that milk of mag. Then a patient with pneumonia presents with the following blood gas. pH is 7.28, your CO2 is 74, and your bicarb is 26. Which of the following is the most appropriate nursing intervention? Okay, so are we going to A, administer a sedative, B, place the patient in a left lateral position, C, place the patient in a high Fowler's position, or D, assist the patient to breathe into a paper bag? So first off, you've got to know what that ABG means. So pH 7.28, CO2 74, and bicarb of 26. What do we have?
Compensated respiratory acidosis.
Very good. So what are we going to do for that patient?
High Fowler's position.
Absolutely. Absolutely. Very good. We are going to sit them up so that they can breathe better.
What did you say, Miss White? What did you say the pH is?
pH is 7.28.
Wouldn't that be uncomfortable?
It's uncompensated.
I have to say uncompensated because the pH is 7.28. Uncompensated.
Uncompensated respiratory acidosis.
Oh, okay.
Relax, guys.
Why wouldn't that be the bag then?
Or is that alkalosis?
All right, is everybody with me?
Wait,
All right. So yeah, this patient is uncompensated respiratory acidosis. They're having respiratory issues, so we're going to raise the head of their bed so that they can get some better breathing going on. All right. Next, a patient with COPD feels short of breath after walking to the bathroom on 2 liters of oxygen via nasal cannula. The morning blood gas was pH is 7.36, CO2 is 62, and their bicarb is 35. Their O2 sat is 88% on those 2 liters. Which of the following should be the nurse's very first intervention? Okay, so are we A, going to call the physician and report the changes in the patient's condition? Are we going to B, turn the patient's O2 up to 4 liters nasal cannula? C is encourage the patient to lay down and relax, or D, encourage the patient to rest and to use pursed lip breathing?
D.
So we're going to do D. So this patient with COPD, they have compensated respiratory acidosis, and they're sat in 88% on 2 liters. So really not that bad. So something simple we're going to do, we're going to get them back in the bed, get them comfortable, raise the head of their bed, and just have them practice that pursed lip breathing to try and relax and chill and regain their breath. And why don't we want to crank up their oxygen?
CO2 narcosis.
So retain that CO2.
Absolutely. So we could increase their CO2 levels and cause that CO2 narcosis because some of your COPDers cannot get rid of that CO2. So it builds up, causing that CO2 narcosis, which is going to lead to decreased level of consciousness, confusion, and potential respiratory arrest. Okay. All right, then a patient who had recent surgery has been vomiting and becomes dizzy while ambulating to the bathroom. After assisting the patient back to bed, the nurse notes the patient's blood pressure is 55/30 and a pulse is 140. Whew. The nurse anticipates the physician will order which IV fluid to correct the condition. Okay, so are we going to give D5 half normal saline at 50 mLs an hour? Are we going to give 0.9% sodium chloride bolus? Are we going to give 0.45% sodium chloride bolus? Or are we going to give D5W at 125 an hour?
0.9 bolus.
Yeah. So this patient is vomiting and dizzy, and they have a terrible blood pressure of 55/30 and a heart rate of 140. So they are super dehydrated. So we are going to call that doctor, let them know, and they're going to order a normal saline bolus. So that means we're going to hang that 0.9% normal saline, and we are going to set that IV flow rate on the pump to 999. As wide open as it will go, because we want to get that fluid in quickly so that we can quickly raise that blood pressure. Okay. All right. Next is a patient with renal failure presents to the ED after skipping 3 dialysis treatments to visit family out of town. Which set of blood gases would indicate to the nurse that the patient is in a state of metabolic acidosis? Okay, so pH of 7.43, CO2 of 36, and a bicarb of 26. A pH of 7.41, CO2 49, and a bicarb of 30. A pH of 7.33, a CO2 of 35, and a bicarb of 17, or a pH of 7.25, CO2 of 56, and a bicarb of 28. I know that's a lot of numbers.
Is it C?
Absolutely C. So they are in metabolic acidosis with a pH of 7.33, CO2 of 35, and bicarb of 17. Then a patient with a small bowel obstruction has an NG tube connected to low intermittent suction for 2 days. The nurse should monitor for clinical manifestations of which acid-base disorder. So if we're sucking out all their gastric content through the NG tube, what are we putting them at risk for?
Metabolic alkalosis.
Yes, metabolic alkalosis. We're sucking out all their stomach acids. So metabolic alkalosis. All right. The nurse is caring for a patient with a respiratory rate of 32 and is complaining of lightheadedness and tingling in the fingers. Which is the appropriate nursing intervention? Are we going to monitor intake and output? B is encourage patient to increase activity. C, institute deep breathing exercises every hour. Or D, provide reassurance to the patient and administer sedatives. So these people are hyperventilating, right? Breathing 32 times a minute. They're lightheaded and tingling. Sounds like they're having a panic attack. So what is our blood gas? What result does that give us? Alkalosis, acidosis.
Respiratory alkalosis.
Respiratory alkalosis, absolutely. So we're going to provide reassurance. All right, then a patient with a recent thyroidectomy complains of numbness and tingling around the mouth. Which other findings indicate low serum calcium levels? So they had their thyroid removed and know that your parathyroids are attached to your thyroid, right? So if you take that out, you're going to have low calcium levels. So are we going to anticipate dizziness, decreased deep tendon reflexes, a positive Shavastic sign, or nausea?
See?
Yeah, we're going to have that positive Shavastic sign with low calcium. All right. Then a nurse is admitting a patient with a potassium of 6. The nurse anticipates this finding is likely a result of which condition? Acute renal failure, malabsorption syndrome, nasogastric drainage, or laxative abuse?
Renal failure.
Yeah, renal failure. The kidneys don't want to work. They hold on to everything. All right, here's your nutrition question. So the nurse is assisting the patient with a serum sodium level of 158 to order their dinner. Which items should the nurse teach the patient to avoid? And this is select all that apply. So their options are pretzels, baked chicken, chicken bouillon, ham and cheese sandwich, or tomato soup.
Avoid ham and cheese.
Definitely chicken bouillon to avoid.
Definitely pretzels.
Pretzels.
The ham and cheese.
So the only thing out of that list that they can eat is going to be that baked chicken.
Yeah.
Okay, because your pretzels are salty, your chicken bouillon is nothing but salt. Ham and cheese, that's going to be processed foods that are high in salt. And then your tomato soup is really salty as well. Okay. All right. Then a nurse is caring for a group of patients while reviewing the patient assignment. The nurse determines which patient is at greatest risk for fluid volume deficit. A patient with an ileostomy, a patient with congestive heart failure, a patient with decreased kidney function, or a patient with a fever of 99.5.
Could you repeat the question? I'm sorry.
A nurse is caring for a group of patients While reviewing the patient assignment, the nurse determines which patient is at greatest risk for fluid volume deficit. So a patient with an ileostomy, congestive heart failure, decreased kidney function, or a fever of 99.5.
Ileostomy.
Ileostomy. So congestive heart failure and decreased kidney function, they're going to be at increased risk for fluid volume excess, right? But a fever of 99.5, you're probably not diaphoretic enough with that to lose much fluid volume. So with your ileostomy, because those typically tend to put out liquid stools just nonstop. So they are at the greatest risk. Then a patient is caring for a patient who's been receiving IV diuretics and is now experiencing a deficient fluid volume. Which assessment finding would the nurse expect to find in this patient? Are they going to have crackles in their lungs, a decreased hematocrit level, an increased blood pressure, or an increased heart rate?
Hematocrit level?
Anybody else? This patient is experiencing deficit fluid volume or fluid volume deficit. So they're dehydrated.
Increased
They're going to have crackles. They're not going to have crackles. Are they going to have an increased blood pressure?
No.
No, low blood pressure.
It's going to be low. So they are going to have an increased heart rate because your body's trying to compensate and raise that heart rate so that you can raise that blood pressure. So it's not the decreased hematocrit level because you're going to see that with fluid volume excess. Remember, in fluid volume deficit, all of your labs are going to be elevated because they're going to be concentrated because, no, scratch that. Back up. I said that wrong in my head. So if they are fluid volume deficit, I just totally confused myself. Hang on. Hold that thought because my brain just died. Okay, so your hematocrit is going to be increased because of hemoconcentration. So you have less fluid, so everything's going to be concentrated in that little bit of fluid that you have. So you're going to have an increased hematocrit level. So the opposite, if you have too much fluid volume, you're going to be diluted. That way you would see a decreased hematocrit. Okay. Then which patient is at greatest risk? We've already done that one, never mind. And then last but not least, a patient is admitted with congestive heart failure. So that tells you that they have fluid volume excess, right? So on assessment, the nurse notes that the patient complains of dyspnea and you note crackles in the lung bases. The nurse anticipates the physician will order the following. So do you think he's going to order daily weights?
Yes.
Absolutely. Do you think they're going to order normal saline at 50?
No.
I sure hope not. If they do, you need to call them. They're already in congestive heart failure. They've already got too many fluids, so we do not want to give them more fluids, okay? And let me tell you, doctors will overlook that, and they will write that order, and you have to call them and say, are you sure you want to do that? Okay. Are we going to give them Lasix?
Yes.
Absolutely, because we want to increase their excretion so that they are getting rid of that fluid. Are they going to be on a regular diet?
No, they might be on a.
So what kind of diet do you think they'll be on?
Gluten restriction diet.
Food restriction.
Low restriction or sodium restriction. Have a low sodium diet. Will we put O2 at 2 liters on them to keep their sats greater than 95%?
Maybe so, yeah.
Yes.
Yep. How about out of bed with assistance?
Yeah.
Absolutely. We don't want them getting up without help. All right, and that is all I have. Do y'all have any questions?
Can you post
Miss
that on
White.
Blackboard?
Miss White.
You'll have to give me a little bit to type it up because I don't have it. I think I just have it solely like this, but I can if you'll give me time.
Yeah, we give you time.
Thank you.
You can scan it.
Can you
It's
post
got a
the
whole bunch of
questions that may or may not be on the test?
I will also post the little study guide and kind of helpful tips.
That would be nice.
What to remember. I don't know what else I was going to tell you. Any other questions?
Remember.
Let me see what.
Is it 50 questions?
Yes.
We have intake.
I'll make you a blueprint too.
Just a question, just to refresh myself. Would we have intake and output math on this?
No.
No, okay.
I don't remember if I have any math on this one. I'm sure I do somewhere, but no, there's no intake and output. But you better know what the minimum urine output is.
30.
Right. Anything else?
Oh, Jesus.
This is a tough test. I know it is. That's why I try to provide that little helpful hints and cheat sheet to try and bring everything into focus. Because I know it's hard, but I've had people make 100 on it before, so I know it is doable.
It won't be me.
I know it's a hard test. So, any other questions before we head out?
Miss White, you were talking about a cheat sheet on Blackboard. I don't think I saw that. What were you talking about?
She hasn't posted it.
What, posting the stuff on Blackboard? Or teaching
Yeah.
on Blackboard?
She hasn't posted it yet.
Oh, okay.
Yeah, I haven't posted. I've actually have it posted. It's just not visible to y'all yet. So I just have to go in and change the settings.
No, it's for the test. It's not posted yet.
Yeah, the cheat sheet. For
Oh, I was talking about the one with the food. For
Yeah, that's already posted.
That should still be up there. And you do want to look over that because you want to know examples of what your patient can and cannot eat.
where can I find it?
Let me see if I can figure out what it's called. See if this is it. It's fluid and electrolyte. Oops, I just clicked on the wrong thing. Look under electrolytes, and it says nutrition and electrolytes. And it has a picture of a foot on it. Yes. All right. If I don't have anything else, I'm going to go feed my kid who's sitting in front of me staring at me wanting lunch. All right. If y'all have any questions, just email me and let me know. All right.
Okay, thank you.
All right. Bye.
Bye.
Bye.